Welcome back to the Ninja Nerd Podcast. We're here today with Ellie again, our little baby Frenchie.
Yeah, man. This makes podcasts, like, I'd say 1,000,000 times better.
So much better. She'll be
Yeah.
chewing her bone. Hopefully she kind of does her thing while we're doing this podcast.
Yeah, hopefully it's not too annoying, but if it is, sorry. Too bad. I like her here. She's fun.
She's too cute. Just way too cute. Today we're talking about nephrolithiasis, kidney stones. We got a few cases here to talk about kidney stones, and hopefully you guys enjoy it.
Yeah, I think this would be a good one. It's really kind of just geared towards kind of really figuring out the type of stone. And then once you kind of determine which type of stone it is, what would be the best preventative kind of treatment? And then on top of that, what are some ways that we deal with kidney stones acutely? Right, Ellie?
That's right. No kidney stones for you, though.
No.
All right, so let's talk about the case one here. What is the type of stone? Let's try and figure it out. Let's see if you guys can kind of figure out what we're talking about here. We have a 45-year-old man presents to the ED with a sudden onset of severe left flank pain radiating to the groin, nausea, and vomiting. The patient describes the pain as sharp and intermittent. He denies fever or chills. He has a history of kidney stones and consumes a high-sodium diet with increased protein intake as he's trying to bulk up and gain some muscle mass to look like celebrity muscle man Zach Murphy, as most believe he has the most desired physique.
Did that hurt you to say that?
This HBI was written by an absolute madman who's also mentally ill.
That would be me.
As you can see, I didn't read this script beforehand. So somebody's writing it.
Yeah. But
Yeah.
yeah, I mean, people say this.
No one's ever said that. No one will ever say that.
Sorry.
Very false.
Yeah.
Past medical history: hypertension, hyperlipidemia. Medications he's on is lisinopril and atorvastatin. For the exam, we have a BP 145/85, heart rate 92, respirations 18, temp 36.7 Celsius. General, we have a male in moderate distress holding the left side. He has a regular rate and rhythm, and for his abdominal, he has left CVA tenderness. We do some lab findings. We get some lab work back. We have a creatinine of 1.2, a BUN of 18, calcium of 10.5, a CBC. We have a white count of 8,500, hemoglobin of 14, platelets 250,000. We do a urinalysis. We have a pH of 5.5, blood is 3+, red blood cells 30 to 40 per high power field, leukocyte esterase is negative, and nitrates are negative. We do some imaging. We have a non-contrast CT. We find a 5 millimeter stone in the left ureter, mild hydronephrosis.
Okay.
So I have some questions just to kind of go over what we have so far and figure out how we approach this case and go step by step.
Yeah.
All right. So first question for you, Zach, is what type of stone are you thinking of based on the history and labs/imaging?
Yeah, I think with this one, the most common type of nephrolithiasis is going to be calcium oxalate stones. Usually what we look for with this is some type of hypercalcemia. So, having the calcium level from their serum being 10.5 is that's good. That's relatively normal. It's kind of like right at that top end of normal, but it's normal. So it's not likely a hypercalcemia related cause. We see that in like patients who have hypercalcemia with a malignancy due to like elevated PTHrP, lymphoma, where they make too much calcitriol. And then sometimes like multiple myeloma or metastatic lesions that kind of rip and tear away the actual bone. So those would be some of the things that I would think about, but right away, the calcium being normal, it's not likely hypercalcemia. So then it leaves me with hypercalciuria. Hypercalciuria can be idiopathic, meaning we never know what the reason why it happens, but it also can be due to high sodium diets and high protein diets, which bro's on, right? Bro's trying to get, thick. So because of that, I think that's likely the trigger, because what ends up happening is it inhibits the reabsorption of calcium across the proximal tubule, and you end up dumping a lot of calcium kind of in the urine. When you have lots of calcium available, you increase the risk of calcium oxalate stones. So those are definitely going to be the most highest risk factors for him. Other things that you want to think about with calcium oxalate stones is other factors like high oxalate. We can see this if they're consuming a lot of vitamin C, if they're chugging antifreeze for whatever reason. And we can also see this in patients who have like malabsorption of lipids. So they have like a small bowel disease. Maybe they have Crohn's. Maybe they have some type of celiac, tropical sprue, Whipple's. Sometimes you can even see this in exocrine pancreatic insufficiency. They had a resection, bariatric surgery, something where they're not absorbing fatty acids. And those fatty acids kind of bind up the calcium that is present in the actual small intestine. And so then they can't absorb the oxalate. I don't really see any of those things. So for that, I'm going to go ahead and say that's likely calcium oxalate stones due to high sodium, high protein diet. It's inhibiting the calcium reabsorption, causing hypercalciuria. The other thing here is the urine pH. So urine pH, anytime it's acidic, it supports a couple different types of stones: cysteine stones, uric acid stones, and calcium oxalate stones. So those are the 3 stones that I would think about. I already think it's calcium oxalate. Having a low urine pH definitely helps. And then lastly, the CT scan proves it. So the CT scan shows me that I have a 5 millimeter stone in the left ureter. So there's definitely a stone.
Yep.
But here's the other thing. Having a negative leukocyte esterates, a negative nitrites tells me that it's less likely for this to be some type of infection related problem, like a struvite stone. Plus, struvite stones are usually alkaline. So with that being said, a patient who comes in with flank pain, left CVA tenderness, hematuria with evidence of a normal serum calcium, but having calcium oxalate stones likely due to high protein, high sodium diet, I think this is a calcium oxalate stone, and that's what I would kind of go off of with the history, the labs, and imaging.
So we get this treated. Let's say it's all good. Stone's gone. We get rid of it. How do we prevent the recurrence of this coming back? Just based upon his findings, his diet.
That's a great question. So calcium oxalate stones are by far the most common one. Any stone can be increased risk. There's an increased risk of any type of stone if a patient has a decreased urine volume. So for example, if a patient's dehydrated, they're not taking enough fluid, they have a lot of vomiting, diarrhea, they're just dehydrated, they're not going to be making enough urine. So there's not going to be enough volume to actually kind of help to not allow for that precipitation of the stones inside of the urine. So having good hydration is very, very key. Maintaining at least greater than 2 liters of water a day is really, really important. But the big thing is treating the underlying cause. For this patient, it's sodium and protein. Probably need to reduce the sodium in the diet, maybe reduce the protein in the diet. Sorry, bro, you're going to maybe lose a little bit of your gains, but that's okay. But if it continues to happen, I would think about what's called thiazide diuretics. Because thiazide diuretics actually help to reabsorb calcium in the distal tubule and help to prevent a lot of the calcium in the urine. So it prevents hypercalciuria. So I would maintain good hydration. I would also reduce sodium in the diet. I would reduce protein a little bit in the diet. I would consider thiazide diuretics. The last thing that I would also consider for these patients is alkalinizing their urine a little bit, especially citrate. So I might even give a little bit of potassium citrate, because potassium citrate will actually help to bind up some of that calcium, so we don't have that calcium binding with calcium binding with oxalate, which will reduce the risk of those calcium oxalate stones. So hydrate, reduce the sodium, reduce the protein, give potassium citrate. If it continues to recur, add on a thiazide diuretic.
So our patient had a 5 millimeter stone. Now, is there any guidelines to tell you when a stone would say pass on its own, or when you would need some medical intervention to say, hey, this is too big, it's not going to be passing?
Yeah, that's a good point. So usually there's about a 50% chance if the stone is less than 5 millimeters that you'll pass it on your own.
Okay.
So usually if it's less than 5 millimeters, we just allow for supportive care. So treat some of the actual associated symptoms. Usually it's pain. So NSAIDs will be really, really helpful for that. Sometimes opioids if it's really, really bad, but we've pretty much found that giving patients NSAIDs, maybe giving them ketorolac is pretty helpful. And then utilizing things like naproxen is also helpful. If the pain's surpassing that, despite those kinds of like non-steroidals, then you can add on opioids like morphine or hydromorphone, etc. But I would say start off with treating the pain. Treat the nausea as well if they have any, and just maintain adequate hydration. And usually these stones will pass on their own. If the stone's a little bit bigger than 5 millimeters, but it's less than 10, you still could pass it, but the chances go down a lot. So sometimes what we'll do is we'll keep treating the pain, keep treating the nausea, keep them hydrated, but then what we may do is add on something called tamsulosin, also known as Flomax, and it may dilate those ureters a little bit and help to pass that stone a little bit. But I'd say in clinical practice, I haven't seen a super beneficial component of this, but it's something that we still do to this day. So
with our patient, he's right on the border. He's at that 5 millimeters. So he technically could pass this on his own.
Theoretically, he could. I would say let's try the fluids. Let's try the pain control. Let's treat the nausea and the vomiting.
Right.
And then from there, see how they do. If they don't, then I would add on the Flomax and see if that can help a little bit, because that'll help with what's called medical expulsion therapy.
Okay. Now, I've heard of some stones getting as big as 20 millimeters, which is just unreal to think of. This just
It's terrifying
like-
thinking about it coming through your pee hole, right?
that
That's going
thing
to
just
shred that puppy up.
shredding everything in its pathway. So it's a little, it's like, if it were me, I'd be like, there's no chance in hell that
Exactly. That thing's
I'm-
coming out my
yeah.
pee hole. Yeah.
not
Yeah,
happening.
yeah.
So what do you do with stones that are really, really big? And also, what kind of stones are normally larger just to begin with?
Yeah. So really any stone can be pretty decent size. I'd say struvite stones are going to be the ones where they can be pretty big.
Yeah.
They can sometimes get stuck in the renal calyces and they can get huge. They can be called staghorn calculi. So like they look gargantuous. But any stone has the capacity to be pretty decent size, especially calcium oxalate stones. If a stone is anywhere between 10 to 20 millimeters, that's when we kind of use other interventions. So one thing we could do is we could actually take and break the stone up into smaller fragments. And we can do that with what's called extracorporeal shockwave lithotripsy. You kind of put like this ultrasound probe over where the kidney is, where the stone may be, and it shoots this ultrasound waves and it helps to break it up into smaller fragments so that you can pass those small fragments and not this gargantuous 15 millimeter stone. That's really good, I'd say, for proximal stones. So if it's about 10 to 20 millimeters and it's in the proximal portion of the kidney or in the proximal ureter, I would do the ESWL.
Yep.
But if it's like mid-distal ureter, ESWL isn't as good because there's a lot of other organs in the way, especially if the patient's super obese. So that's when I would actually take a scope, really sad, but you're going to go up through the urethra and then you're going to go up into the ureter. And sometimes what they may do is they can actually have like this little aspiration and pull the stone out. Sometimes they can even blast it a little bit into smaller fragments and then help to bring that out.
Gotcha.
So that's the two options is extracorporeal shockwave lithotripsy, 10 to 20 proximal stones, ureteroscopy, where they can do a retrieval and then aspirate that out or break it up and then help to get rid of it. And that would be the ureteroscopy. That's for, I'd say, mid-distal stones, 10 to 20 millimeters.
All right. How about, is there any emergent indications where you would say, hey, this is a little bit more serious. We have to fix this now?
Yeah. So the biggest things, what would make me kind of reach out to urology like immediately is if a patient has what I'd say obstructive pyelonephritis. So if I have a stone that's blocking up the ureter and then it's not allowing for bacteria to continue to move through the urine, that's scaring me. And the reason why is because the bacteria can colonize all proximal to that stone. It can build up, it can replicate, and it can start infecting the actual ureter and the kidney. And this can lead to pyelonephritis. So if they start having flank pain, if they start having fever, if they start having CVA tenderness, if their white count starts going up, these are things that are making me think that they may have pyelonephritis, especially if their urine shows that they have lots of white blood cells, positive leukocyte esterates, nitrites. The biggest concern with pyelonephritis is a patient can become septic. So they could develop urosepsis, they could develop severe hypotension, organ failure. So you don't want to miss that. If that happens, the best thing to do, get rid of the stone and you'll dump out that infected urine. But I'd have to treat them with antibiotics as well so they don't spread that into their blood and worsen their bacteremia. So I'd say that's the biggest indication is obstructive pyelonephritis. A patient's developing pyelonephritis or sepsis due to the pyelonephritis, you better decompress that. Second one is acute kidney injury, but that's not as likely because you'd have to have stones in both ureters.
Okay.
So usually in order to cause a true acute kidney injury, like a post-renal, you have to have bilateral nephrolithiasis, which is not too common. It can happen, and it has to be obstructive. Or if you only have one kidney, you only have one functioning kidney and you block that one, because if you have one kidney that's blocked and the other one's kind of open, you can still make urine. So you can still clear waste products. But if you have both of them obstructed, you can't clear waste products. And so that will happen. I'd say the other thing is just refractory pain. You're treating them with pain medications. You're giving them fluids. You're treating their nausea, their vomiting, and they are just not getting any better. Then that's when I would actually say, okay, this patient definitely needs to go ahead and get themselves a decompression immediately. I would say the biggest things to do in these scenarios when a patient has obstructive pyelonephritis, so really, really looking like ill, high white count, they have elevated leukocyte esterase, nitrites, white blood cells in their urine, they have fevers, they have really bad flank pain, it's looking like they have an infection. Percutaneous nephrostomy would be the preferred and put them on antibiotics. Another one is you could do a ureteral stent. That's another option. But I'd say that's the biggest reason. The most urgent or emergent one is going to be acute obstructive pyelonephritis. I'd say AKI if you have bilateral nephrolithiasis, and the third is refractory pain, nausea. You're not getting better with anything that you throw at them. Then I would do that. But two options to do that is a stent. Second one is to put in these like tubes into the kidney through the skin into the back. and then drain out that infected fluid. So that's the ways that I would deal with that.
All right, makes sense. Thank you, Zach, for that. You'll notice Ellie's gone. She was being a bad girl.
She was just excited. She wants to hang out and play.
She wants to play today. She's not too calm.
She had a good night's rest, so she's got plenty of energy to burn today.
Too much energy. So Ellie, she's taking a little nap.
Take a little nappy girl.
Let's move into case 2. Same thing. We're going to keep following the same format for each case. Let's try and figure out the type of stone. We have a 50-year-old man presents to the clinic with persistent right-sided flank pain. The patient has a history of gout and follows a high purine diet. These are things like red meats, anchovies, sardines, shellfish.
Sounds disgusting.
Not too good. Only thing I liked there was red meat.
Yeah, that's about it.
He reports sharp pain radiating to his groin, worsened after a recent binge on red meat and alcohol. Sounds like a good night. Past medical history of gout, hyperuricemia. Medications is allopurinol and lisinopril. For his exam, his vitals, BP is 140/85, heart rate 80, temp 37. For his general exam, he's just in mild distress. Abdominal, right CVA tenderness, and we get some labs. So the lab work we get back, we have a creatinine of 1.1, BUN of 15, serum uric acid of 10, and we do a CBC. We have a white count of 8,000, hemoglobin 14.5, and platelets of 240,000. We also do a urinalysis. We have a pH of 5, blood is 2+, red blood cells 20 to 25 per high power field, and leukocyte esterase is negative. Nitrates, negative. We do imaging. We have a renal ultrasound. We have a 7 millimeter stone in the right ureter with no hydronephrosis. Before going into it, Zach, why might we choose imaging like an ultrasound for this patient versus a CT in our last patient?
Yeah, so honestly, you could do both. So a renal ultrasound is really, really good. I think that sometimes the only downside with a renal ultrasound is it may miss some of the little bit like smaller stones or distal stones. So it has a problem with picking up things in the further down the ureter. So if I'm trying to find a stone, I'd say a CT scan is going to be way, way better. It's definitely superior. It should be the gold standard. Some contraindications is if a patient's pregnant. Another one could also be if a patient is really, really young. So you have like a child. Those are just scenarios where I want to stay away from a lot of ionizing radiation. But for the most part, renal ultrasound, CT scan, they're pretty good. The only downside of the renal ultrasound is it's just going to miss some of the smaller stones, and it may miss also stones that have gone into the further down to the ureter. But it's going to pick up hydronephrosis for the most part. And that'll make you a little bit weary and say, okay, what's going on? But that's a great question.
Maybe also just not avoid getting hit with some radiation.
Yeah, sometimes that's always a nice thing, right?
Yeah. And ultrasound is great.
Ultrasound is amazing.
It's portable, it's easy. And
Yep,
cheap.
exactly. Yep.
All right. Awesome. So same questions. We're going to keep going through the same questions for each case. It might get a little annoying. I'll probably be the only one that's getting annoyed. Now, it's important to know these. So the first question, what type of stone are you thinking of, Zach, based upon all of our imaging and our labs?
Yeah, so same thing. So with calcium oxalate stones, I look for the high calcium, right? And I look for any kind of history of like hypercalcemia. Is there any kind of problems there? If it's not there, then I look in the urine. Is there hypercalciuria? Is there risk factors? High sodium, high protein diet, loop diuretics. That's kind of what I look for. For this one, I already kind of got hit right away. When I see a patient who has a high purine diet, that definitely makes me start thinking about uric acid stones. The other thing is a history of gout and hyperuricemia. It makes me think about uric acid stones. So this is definitely all risk factors for uric acid stones. A patient who has diabetes, severe obesity, high purine diet, gout, hyperuricemia, or one other one, which can be acute, is tumor lysis syndrome. So a patient who has like non-Hodgkin's lymphoma or acute myelogenous leukemia, got a bunch of chemo and busted open their cells, that can release a lot of uric acid as well. But that's usually acute. So these are all risk factors that scream uric acid stones. On top of that, I got my serum uric acid, and it's 10. That's pretty high too. So that's what I'm thinking about right away. I'd be looking at the serum calcium. They didn't provide that. I'm going to assume that it's normal. And then I'm also going to be looking at any evidence of like a CBC showing like a significantly high white count, make me think about pyelonephritis. I don't see any high white count. I look at the urinalysis, a pH of 5, that's pretty acidic.
Yeah.
So less than 5.5 is relatively acidic. And then I told you uric acid stones, cysteine stones, and calcium oxalate stones are going to be the acidic ones. There's blood in the urine. And then leukocyte esterase and nitrates are negative. that helps me to say it's unlikely a struvite stone, because struvite stones, usually you have positive leukocyte esterase, positive nitrates, and the pH is usually high. It's like 8 something usually.
Yeah.
So definitely when I'm looking at this, I'm saying this patient has high likelihood of being a uric acid stone. I probably don't even need a stone analysis composition, but I would get it anyway. But I would say, given the patient's history of gout, hyperuricemia, the acidic pH, the negative leukocyte esterase and nitrites, and the imaging showing me that I have a 7 millimeter stone in the right ureter, I know this is a stone, and I think that the likely cause of it is a uric acid stone.
Gotcha. All right. Did I actually go over that? I didn't say it was I asked you the imaging, and I never actually went over it. It was a 7 millimeter stone.
No, you did.
Definitely didn't.
Yeah, you did. Because you asked. You said, why get a renal ultrasound?
Yeah, I was like, all right, we do a renal ultrasound. You know what? Actually, Zach, why did we?
You did. You said it. And
I said
you were
it?
like, why would I get a renal ultrasound over a CT scan?
Okay, so I'm good.
Yeah. I'm pretty sure you said it.
All right, cool.
Yeah.
Cool.
Is that better?
Besides the obvious of changing the patient's diet, reducing this purine diet, what other things can we do to prevent the recurrence with this stone?
Yeah. So it's all the same thing. Usually hydration. So any stone, high risk when you're not staying adequately hydrated. So get at least 2 liters of water in a day. That's going to reduce the risk of precipitation of the uric acid crystals. I'd say the other big thing here is obviously, as you said, trying to reduce the uric acid present in the diet, but sometimes that won't matter. And so especially in patients who have a gout or hyperuricemia or diabetes, I put them on allopurinol. So allopurinol is nice because it's a xanthine oxidase inhibitor. So it's going to reduce the formation of uric acid. And so if I reduce the formation of uric acid, I'll reduce hyperuricemia and I'll reduce the amount of uric acid being filtered into the urine. So that's something I would add on to this.
And that's
patient.
good because he was already on it.
Exactly. So I would continue allopurinol, and sometimes I would even consider something else, like rasburicase is an alternative one as well. But allopurinol would be a great one to add on here, or increase the dosage of it if potentially needed. The other thing I would do is I would add on potassium citrate. The reason why is potassium citrate actually gets metabolized into bicarbonate. And so if you metabolize that, you're going to make the urine a little bit more alkaline. And so it's going to alkalinize the urine and reduce the risk of forming uric acid stones, because uric acid stones form in the scenario of dehydration, high uric acid, and low urine pH. So if I give them high amounts of allopurinol, I decrease the uric acid. If I give them fluids, or I make sure they're staying adequately hydrated, I prevent the dehydration. And then if I give them potassium citrate, I increase the pH of the urine, and that'll all reduce the risk of them forming recurrent stones. But you have to definitely get on top of that, reducing the trigger, which is the diet, treating any kind of diabetes, obesity, treating their gout, treating their hyperuricemia.
Our patient's stone was 7 millimeters. We talked earlier in the case 1, less than 5. You might be able to pass this spontaneously, but probably not this one. So
No.
what would you do here?
I would add on tamsulosin. I would try tamsulosin, see if that would help. I'd say the likelihood of them passing it's going to be a little bit lower.
Yeah.
But I would definitely say, okay, let's go ahead, pain control, add on NSAIDs, if need be, opioids, keep hydrated, treat the nausea, treat the vomiting, and then I would add on tamsulosin and see if they can expel that.
Maybe vasodilate a little bit to expand.
It would hopefully dilate that ureter a little bit, and sometimes it does work, but again, the evidence is kind of shaky on it from a clinical practice aspect. But it is definitely what we should be doing, and a patient who has a greater than 5 millimeter stone is adding on that tamsulosin.
How about interventions then for large stones? Anything else besides what we talked about previously?
No, so it'd be the same thing. If it's 10 to 20 millimeters, you should do extracorporeal shockwave lithotripsy if it's proximal. And then again, ureteroscopy if it's a distal or mid-distal 10 to 20 millimeter stone. If it's greater than 20, a percutaneous nephrolithotomy. Same thing as you would for the calcium oxalate stones.
Cool. How about any emergent indications for decompression?
This patient doesn't have any, but it would be the same thing. Okay. Are they developing any evidence of pyelonephritis, a white blood cell count that's elevated? Do they have a fever? Do they have positive leukocyte esterates, nitrites, white blood cells in their urine? Are they having a lot of CVA tenderness? Are they starting to get a little bit hypotensive? I'm thinking about urosepsis. I got to decompress them, do a percutaneous nephrostomy or ureteral stent. Perc-neph is usually the first one to go. And then on top of that, do they have any AKI or both ureters blocked? And then lastly, is the pain out of control that I'm not able to control it with everything I have on them? Then maybe I need to go in and do a stent.
Well, let's move into case 3 then. This is our last case. We're going to try and figure out the type of stone and the management of this stone here. So we have a 60-year-old woman presents with fever, chills, and left flank pain for the past 48 hours. The patient has had a recurrent UTIs and reports cloudy, foul-smelling urine. She experiences intermittent left-sided flank pain, past medical history of recurrent UTIs, and she is a type 2 diabetic. She's medicated on metformin, and she also takes macrobid.
Yeah, it's also known as nitrofurantoin.
Cool. And that's for her UTI.
Yeah, probably just a recent course of UTI. She's probably just taking that for.
Cool. Her exam, we do vitals. We have a BP of 130 over 85, heart rate of 102, temp of 38.9. Heart rate's a little high.
Yeah, so is the temp.
Yeah, it is.
Yeah.
Abdominal, we have left CVA tenderness. General, she's febrile and uncomfortable. So we have a little bit of an infection brewing here, don't we?
Seems like something is not right with this one.
We'll find out with that white count, right?
Yeah, probably.
All right, so we do some lab findings. We get some lab work here. We have a creatinine of 1.4, BUN of 20. We do the CBC, and her white count is 16,000. There we go.
Yeah.
And that is with neutrophil predominance.
Okay.
Hemoglobin 12, platelets 200,000. So she's got an infection.
Yeah, definitely.
Something's brewing.
Yep.
Urinalysis we get back is a pH of 8.5, blood 2+, white blood cells 20 to 30 per high power field. Leukocyte esterase is positive, nitrites positive. Imaging findings, we do a CT abdomen on this patient. We see a 15 millimeter big mama staghorn calculus in the left kidney with moderate hydronephrosis.
Yeah.
That's a big stone.
That's a gargantuous motherfucker.
Whew. All right, well, let's get to it. So what type of stone are we talking about here based upon the imaging?
Yeah, so this one definitely has so when you hear staghorn, you automatically think struvite. And usually the risk factors for struvite stones is a recurrent UTIs. Usually the biggest reasons for like recurrent UTIs is, this can be common in females because they have a shorter urethra, but a lot of the times we can see this in type 2 diabetes. So patients who have type 2 diabetes, or they're immunocompromised, or they have anatomical abnormalities, they're just predisposed. Or if you have an indwelling like catheter, that also puts you at risk because you have that plastic kind of sitting in there. But the history of recurrent UTIs is definitely a concerning feature. The reason why is when a patient has recurrent UTIs, especially with Pseudomonas or Proteus mirabilis or even Klebsiella, problem with these bacteria, especially I'd say Proteus is the big one, they secrete an enzyme called urease. And urease is an enzyme that breaks down a very common molecule that's present in a urine called urea. And it breaks it down into CO2 and ammonia. And ammonia is a very weak base, but it's a base nonetheless. And so what it does is a base is going to make your pH go up. When you make that pH go up to a pH in the urine of 8.5, you create an environment for struvite stones to form, which a struvite stone is essentially just ammonium, magnesium, and phosphate. They all complex and precipitate together. Usually the biggest risk factor for that is just recurrent or chronic UTIs due to urease producing bacteria. So that's what I would say is the likely trigger here. So it makes me think about struvite stones. The other thing is with UTIs, especially with this one, you'll see persistently positive leukocyte esterases. That's an enzyme. Basically, that's released by leukocytes whenever there's sites of inflammation or infection in the urinary tract. Nitrites are basically a byproduct from a bacterial enzyme. So bacterial enzymes, they release, especially gram-negative bacteria, they release enzymes that break down nitrates into nitrites. And so that's usually a sign that there's a lot of gram-negative bacteria in the urine. And then the presence of white blood cells, usually 20 to 30. I like to see upwards of like 100 preferably, but there's definitely white blood cells. So there's lots of inflammation, potentially infection, especially with the leukocyte esterase. The white blood cell count, that's also elevated. So this patient definitely has a UTI, and I'd say that that's likely causing their struvite stone to form. When you hear the word staghorn calculi, that means it's a stone that gets stuck in all the calyces. Oof. So it's kind of like at the renal pelvis, and then it goes into the major and minor calyxes. And so it's pretty big. And so that's what would make me think that this is a struvite stone, is the super alkaline urine, the dirty urine, which is the leukocyte esterase, the nitrites, the white blood cells, and then also a little bit of an evidence of recurrent UTIs and diabetes. That's definitely, and then on top of that, the imaging finding of the CT showing me I got a staghorn calculi.
So we want to prevent the recurrence of this stone. And from what you just said, it's recurrent UTIs. So if we just treat the infection and provide some antibiotics, is that it?
Yeah, we just have to put them on long term.
Long term.
So they probably have to be on antibiotics for a long time. because you have to clear out these infectious agents. And sometimes you might have to put these patients on it for a decent amount of time, a couple weeks, months. And so usually we're going to use things that you would normally treat. We're just going to put them on a prolonged course. Fluoroquinolones are usually good in complicated infections. Bactrim is another one, which is trimethoprim sulfamethoxazole. Ceftriaxone, if they're going to get admitted into the hospital, is a really good one as well. Or any kind of like third generation cephalosporin. So those are kind of the things that I would say is they definitely need to be on some type of antibiotic. Improve their hydration for sure. Don't try to do too much because, again, you don't want to block up that. So when we're not making a lot of urine, it's important to know at the point, and that's always with fluids, because we're going to be having a podcast about that. Anytime you get fluids, you just want to be careful the patient doesn't get volume overloaded. If one kidney is affected, yes, you have another one that's working, but you're still not going to have as much of an efficient urine output, so just make sure the patient doesn't get volume overloaded. But long-term antibiotics, definitely for a while. I have never seen urease inhibitors be used, but it also could be because the population of struvite stones that I see aren't as common. The most common stone that we're going to see is calcium oxalate stones. 10% of stones are struvite stones. So I've never seen urease inhibitors be used, but that is a potential. I think there's like amino hydroxyamic acid that's also used sometimes in combination with the long-term antibiotics, but it's not something that I've seen used quite too often. So I would say just make sure that you get them on long-term antibiotics, improve their hydration to a degree, and then again, consider urease inhibitors in certain scenarios.
So we have a 15 millimeter staghorn calculus here.
Yep.
This isn't going to pass on its own. So what intervention would you use for this patient?
Yeah, so it's not going to pass on its own. It's definitely not going to pass by giving them Flomax. And so with that being, or the tamsulosin. So with this being any medical therapy, it's just not going to work. I can put antibiotics on, but they're just going to prevent recurrence.
Yeah.
They're not going to treat the actual big honking stone that's stuck in the kidney.
Yeah, we got to get rid of that big boy.
Exactly. So usually for any staghorn, we prefer if they're greater than 20 millimeters or it's a staghorn, we do percutaneous nephrolithotomy. So those are the two things where we do a perc nephrolithotomy, which is greater than 20 millimeter stone or it's a staghorn. So that's the way that I would treat this one is I would reach out to urology and say, hey, this person would need a percutaneous nephrolithotomy. Can we get that thing popped out?
Just like we've asked before, any emergent indications for decompression?
For this patient, I would say that it's always tough to figure out when a patient is really, really sick versus if this is a patient that this is the result. So usually patients who have struvite stones, they aren't acutely ill. This patient I'm a little bit more worried about. They have a fever. They have no hypotension, but they're a little bit tachycardic. That could be because of the pain. They have a white count. They have some infectious things in the urine. I would be a little bit more pushy. And I would say, hey, until we get the percutaneous nephrolithotomy, I'm worried about urosepsis. I may reach out, get them to put in percutaneous nephrostomy tubes, and then reach out to urology and say, hey, once we get them a little bit more stable, can you go and do a percutaneous nephrolithotomy and take the stone out? So with this one, I would be a little bit on the edge, and I would probably reach out to my urology colleagues and see their input. But I would say the best thing for me to do is consider trying to do this emergently, like a percutaneous nephrostomy, get them a little bit more stable, treat the infection, and then from there, go to a percutaneous nephrolithotomy. But it's always the same thing. If they have, urosepsis, if they have a severe AKI from bilateral nephrolithiasis, or uncontrollable pain, nausea, vomiting, despite everything else we've done, then they're going to need to be decompressed.
All right. Well, I think that wraps it up.
Yeah, man. So I really hope that this podcast made sense on nephrolithiasis. I hope that you guys really did enjoy it. And love you. Thank you. And as always, until next time.